Right. Good afternoon, everyone. It's so wonderful to have so many interested and engaged folks here already at the top of the hour. We are going to just go ahead and get started. I'm Dr. Qadria Ali, and I am a longtime member of the American College of Lifestyle Medicine, or ACLM, which, as many of us know, is a society of medical professionals united to reverse chronic disease. I'm also honored to serve as ACLM co-chair of the Health Equity Achieved Through Lifestyle Medicine, or HEAL initiative. And I would love to just give a shout out right at the beginning to our HEAL working group that has been extremely instrumental in pulling together today's webinar, as well as the two sessions that will follow later in the year, as we really started to consider how we can bring health equity and really fold it in deeper and deeper and deeper into the practice of lifestyle medicine. So thank you all for joining us, and I'm really eager to moderate this discussion of a panel of really fantastic folks who are doing work in innovative and interesting and complementary ways. So let's kick off today's panel, and it is entitled Beyond Food to Table, Community-Based Approaches to Connect People and Plants. So let us talk briefly about our roadmap for today. So we have an exciting conversation planned, and these are our 3 high-level learning objectives. So we are going to be first talking about community-based partnerships and how they are key and pivotal to executing food as medicine interventions. Then we will get into talking about some of the key ingredients of these partnerships. And we will wrap up by talking about some of the health equity dimensions of this work and how we can continue to evolve and optimize the work that we are already doing. Just a little tiny housekeeping note, we will be doing a Q&A session at the end. And so we just ask to please use the Q&A chat box, and Stacia is going to be reviewing those and compiling so that when we get to our Q&A at the end, we'll be ready to get to as many questions as we can. All right, so before I get started and open the floor to our panelists, I really wanted to just set the stage in terms of what health equity means to lifestyle medicine and why I am such a vocal and active member of ACLM, particularly through HEAL. So many of you know that lifestyle medicine, this is a specialty that's really focused on how we can use various therapeutic interventions to reverse, treat, and also prevent chronic disease, right? But for me, when I think about lifestyle medicine and its extreme potential and effectiveness, my mind immediately goes to who needs lifestyle medicine the most? Who are the communities who have been structurally marginalized for many different reasons, from the quality health care that we know everyone deserves and requires. And I think that lifestyle medicine, when we really marry it with health equity, that is when we get that secret sauce that really potentiates the power of lifestyle medicine to ensure that it's accessible, it's available, and it's also tailored to all communities, again, particularly those who have been disproportionately burdened by the chronic diseases that lifestyle medicine is so great at addressing. And so we birthed a new working group through the HEAL initiative several months ago around how we can broaden some of the conversations that we're having within lifestyle medicine and really bring it to the community, because that's where people live, work, play, pray, and that is where so much amazing work is going on outside of the silos of clinic. And so that's a little bit of background in terms of what brought today's webinar forward and a little bit of what we hope to get out of the conversation today. Just broadening our scope, considering new partners, considering new ways of doing what we love within lifestyle medicine. So with that, I am going to transition into introducing our fantastic panel. So on behalf of HEAL, we are going to start one by one and talk about all of the amazing things that our panelists have done, and more importantly, what pearls they can leave with us, and we will go one by one. So one quick note, our panelist, Dr. Zhu, he has had a patient emergency, and so we're going to start, I'll do his introduction, and he'll join us a little bit later in the conversation. So let us start off with Mr. Dion Dawson. Thank you so much for being here. So Dion Dawson is the founder and chief dreamer of Dion's Chicago Dream, a nonprofit social enterprise that combats food insecurity through logistics and last mile delivery in the Midwest region. His system provides a week's worth of fresh produce to the doorsteps of food insecure recipients and has provided millions of pounds of fresh produce annually to the Chicago region food system, with numerous community jobs created and one powerful movement. Dion Dawson is a food-fighting social entrepreneur, philanthropic leader, and founder focused on health equity through an innovative and logistical lens. Dion's penchant for challenging the solvency of food insecurity through the stabilization of the supply chain has reinvigorated the traditional food distribution model and has been met with worldwide attention. With data-driven operations, consistent quality, and a deep commitment to a resident-informed process that meets recipients where they are, he prioritizes the end user experience. So please join me in welcoming Dion Dawson to the panel. And we will shift to introducing Dr. Laura Fischer. So Dr. Laura Fischer joins us through the Family Lifestyle Program at Children's National. She is both an RD and PhD with research interests focused on nutrition-related disease risk and modification through diet and lifestyle interventions that are targeted towards children, adolescents, and their adult caregivers. Dr. Fischer has expertise in nutrition assessments, counseling, using motivational interviewing, behavioral lifestyle interventions, and longitudinal and multi-generational research design and analysis. She is assistant research faculty at Children's National and an associate member of the Children's Research Institute Center for Translational Research. Dr. Fischer directs the work of the Family Lifestyle Program's FLIP Produce Prescription Program. FLIP RX aims to address diet-related chronic disease and food insecurity in families in the DC, Maryland, Virginia region through empowering families to live healthier lifestyles. Dr. Fischer also holds an academic appointment as assistant research professor within the Department of Pediatrics at GW School of Medicine. So thank you, Dr. Fischer, and special shout out. She and I are close colleagues at Children's National via the FLIP program. And last but certainly not least, we have Dr. Colin Zhu, who again will be joining us shortly. Dr. Zhu is a double board certified physician in family practice and lifestyle medicine. Driven by his passion for the intersection of medicine, food, and nutrition, he's trained as a plant-based chef and health coach. Having worked in general practice, he quickly observed the inefficiencies of the modern healthcare system, leading him to launch the Chef Doc in 2017. This online wellness and lifestyle education platform has been featured in several public-facing publications. Dr. Zhu is an international speaker, an author, and he is also the creator of the Thrive 5 Formula, which is an educational masterclass series that combines inspiration, education, and practical tools around how to implement the lifestyles of pillars of lifestyle. He also is on the board of directors for the American College of Lifestyle Medicine, and he's also the current chair of the ACLM Food as Medicine / Culinary Medicine member interest group. All right, so let's welcome Dr. Zhu, who will be with us very shortly. So after these really impressive introductions, I would love us to really get into our conversation for today. So we are going to shift into thinking about why we're here today. So I would love, let's see, we are going to start off by thinking about community, because when we think about community-based interventions of any kind, we have to consider people first, right? Who are those individual people who make them up? So I'd like to know how each of you began working with your particular population in the important area of building greater nutrition security. So Dr. Fischer, I'm going to actually start with you. If you wouldn't mind setting the stage around how to bring food as medicine to communities. How and why did you begin engaging with the communities with which you work towards the goal of improving nutrition security and health? Thank you, Dr. Fischer, if you wouldn't mind.
Unmute myself. Hi. Yeah.
Hi.
Thank you so much. I'm really pleased to be part of this conversation today, and thanks for everybody who's joined us. It's really exciting work that we're all doing together. So yeah, I'd like to just start off by talking about how we got this started at Children's National Hospital. It was really born out of a legitimate need that was observed in the patient population. The setting of FlipRx in Children's National Hospital is Washington, D.C. And if you know anything about Washington, D.C., you might know that it's a place where there's a huge disparity in all sorts of factors. Not least of these is income, access to jobs, affordable housing, and access to affordable and healthy food. And so in a place where a lot of patients don't have access to healthy, affordable food, in treating them, in treating their diet-related chronic diseases, it's really doing a disservice to say, we want you to eat more fruits and vegetables, we want you to eat healthier, without really addressing their ability to access those healthy foods. So, for example, in DC, there's only about 3 full-service grocery stores for about 170,000 families. So it's really, really limited. People have challenges accessing fresh, healthy, affordable food, not only in terms of location or transportation, but also there is an added cost, I think, for people who especially are experiencing limited resources. That added cost comes in the form of stress and anxiety around potentially wasting any food that they might purchase on their own. Because oftentimes when it comes to folks who are food insecure or lack access to healthy, affordable food, they'll often prioritize foods that are highly palatable and highly processed. And those are the foods that really contribute to those diet-related chronic disease risks. And so in telling folks, hey, eat better, eat more fruits and vegetables, eat less processed foods, eat more plants, we weren't really doing enough. Just telling folks that they needed to do this really wasn't doing enough. And we heard from people, hey, yeah, I would really like to do that, but it's difficult where I live and how much I have to spend on food and groceries per month. There are seemingly insurmountable barriers to achieving that kind of healthy eating. And so at Children's National, we did start a screen and intervene pilot. And historically, the original intervention was simply a list of resources. Call this food bank, go to this location where you could get food, just a list. Oftentimes that list really maybe even didn't leave the clinician's exam room with the family. And so families were expressing a need for more help, and also clinicians were expressing a need for better tools. And so we wanted to be able to meet the needs of clinicians and families. And so we decided to try a pilot to see if giving free access to healthy food could help change that kind of paradigm around eating healthy and affordable food. So to summarize, this really came out of the legitimate need that we saw in the patient population. We're telling people to eat healthier. They're telling us, I want to, I really do, but it's difficult. There are barriers. And so we're trying to address those barriers.
Thank you so much, Dr. Fischer. That was a very rich answer that I think you hit on so many of the important dimensions when we talk about bringing food as medicine to the community. So I really appreciate you setting the stage for us. So I would love to turn to you, Dion, and thinking about as you began your work, which is very embedded in the communities in Chicago area, how did you go about assessing the needs and strengths and the priorities of the community in which you were seeking to work with Dion's Chicago Dream? And my second part is kind of what have you learned in that process?
Thank you. Thank you everybody for being here. I'm happy Dr. Fischer went first, so you all won't get tired of me talking too much. I always love to be a nice second hitter. But I mean, here at Dion's Chicago Dream, what we're doing is it's anchored, and is everything community. And a lot of times when we think about that, what I love to tell people when we think about, the work of health equity, food as medicine, any type of food intervention or health related diseases, you want to be careful to level set. You know what I mean? When we think about, the word love, we know the word love means something different to each person. So when we talk about community, the word community means something different in every culture and in every community, on every block. And so what we wanted to make sure, and what I've learned from the beginning was what is community and what is community going to mean for us? And for us, community, number one, did not mean creating a Black response to a Black problem. You know what I mean? And so what we wanted to be was a Black-led organization that created a response that everyone could use. And so when we're thinking about community, community is all inclusive. Community involves everyone. Community is a type of conversation. It goes from one side to the other. You're playing telephone. And as you're losing stuff, you're trying to pick it up. And in this process, we started in the community on a single block. And I'm thankful for that, because the biggest thing about community is we learn to listen. You know what I mean? And I think that anywhere in every state, country, block, neighborhood, there's always a group who's the listeners. You know what I mean? And I think that, when you have those listeners, especially when you're talking about health equity, food is medicine, and food distribution, a lot of times we don't have a lot of listening. You know what I mean? Historically, we have a lot of talking we have a lot of food drop-offs, even though we know that, up until now, the problem has evolved and grown to a point where we can't really ignore it anymore. And so, for us, we started in the community, we started in the pandemic, but we also made sure that we never lost sight of understanding at the most basic level that people need access to healthy options consistently. And so, the good thing about, where we've gone from starting in 2020 with no money and no idea of what we're doing to being a $5 million organization, we've created more than 37 wage-paying positions. We've never registered a single volunteer hour. We've never taken a single piece of donated produce. We've never lost sight of understanding that people need food, and in order to live a healthy life, in order for food is medicine to really land, because we also know that it's still kind of in the air right now. We know that, as we expand the 1115 waivers, as more states adopt it, as we're really getting into those implementation phases, we want to make sure that if we're going to land this, that we don't lose sight of the main thing being the main thing. And for us, we understand where we started, but we don't lose track of going upstream, because what happens is there's this little negative connotation sometimes with community, with it being limited in scope. And so what we've been able to do is continue to go upstream and connect with those medical providers, connect with the national federal strategy, connect with USDA, so that we can make sure that there's this kind of continuity in place, so that there's things not lost in translation. And I'll just use an example of me being a Navy veteran. A lot of times people do not understand that your active duty medical record is not transferred over to the Department of Veteran Affairs. Those two things never talk. And so what happens is as you're transitioning, not only do you have to have all of these hard files and things like that, but also you have to make sure that things are up to date, things are accurate, and you don't lose sight of making sure that your health and wellness is maintained. And so when we think about that, for us, we have community that was never really connected or rooted in the healthcare system and the food system. And I don't think that when we're thinking about assessing needs, trends, priorities, and the agenda, that one can be great without the other being great. I think we're finding this food is medicine moment showing how both of them are dependent upon each other. You cannot have, medicine and food related interventions really, be impactful without a food system that is connected and that is representative of everyone. And so for us, it's just really understanding how we've been able to evolve, innovate, and also make sure that we're being, represented at every level, not just going to Black neighborhoods to understand the need, but being Black in representation when we talk about connecting the supply chain to the food is medicine movement, so that we can make sure that we're building on top of each other.
I love it. There's so many key points that both of you have shared, just the importance of really, again, like acting outside of our silos, the importance of being broad, but also focused on the people that you're serving and letting them define on their own behalf what's important. And also knowing that like no two solutions or kind of, it won't look the same in every community. I'm curious from both of you, given like kind of the focused context of your work, We have the healthcare embedded produce prescription program. We have this, direct to resident produce delivery model that's also so much more. Who have been some of the key partners when you think about thinking broadly, when you think about impact? Who have been some of those key partners that have been integral to the success of your work? And I'd love both of you all to think about this question for us.
Yeah, I'd be happy to start. I think I really want to just echo what Dion has said about the community, not just being, residents who live in the neighborhood, but community being all of the people, all of the stakeholders that are part of the program or project or what you're doing. And that includes other community partners and other food systems or distributors or other clinics. So thinking about community in a broader perspective has been really useful for our program and the success of our program. We think about community as in including the clinicians that we work with and really understanding their perspective and their needs and making sure that when we're really evaluating what we're doing, we're asking ourselves, are we meeting the needs of our entire community? And that includes, yes, the residents that we serve, but also the clinicians who are seeing these patients. Are they seeing that, yes, this is a tool that my patients are using and are benefiting from? Or similarly, another stakeholder in this work is insurance companies, for example, people who are tasked with covering the costs for patients. And so we've tried to partner with many community members, thinking about community in that very, very broad aspect of residents, clinicians, healthcare payers, even policymakers and advocates and other community organizations doing similar things. And in this broad perspective of community, we often find that synergy is so much more effective than, we're greater than the sum of our parts together. We have so much more impact together than we do alone. And so your question was about what community partners have been important. And so I mentioned residents, clinicians, other community organizations. I want to also mention what has been really important for us is a food distribution partner who has the capacity to serve our patients. We've been really lucky to work with a very established food hub who has the capacity to deliver to a wide range of neighborhoods that we serve. And so, I've heard of other programs who are working this out and they take it all on sometimes, in the greatest, with the largest heart thinking we can do it all. But we really need to have partners, especially food distribution partners who are able to work with us, because we cannot do it all. We cannot do it all alone. Food distribution partners have been really key.
Wonderful. Thank you so much, Laura. Now, I know that I wanted to initially open this one up to Dion and Dr. Fischer, but I just noticed that Dr. Zhu is in the house now, and I'm sorry, it looks like you've been patiently waiting to come up on stage. So welcome. And I did want to share a question with you, actually, Dr. Zhu, because you have a very unique perspective when you think about being a physician chef and also educator. So I'm curious from your perspective, Dr. Zhu, who those key players are from the perspective of really having that goal of connecting individuals and communities, with a broad definition of community, with health promoting foods and also the skills to effectively use them. One thing that we know within food as medicine is that the produce is an important part, but that's part of the whole equation when you think about helping people to establish those skills. So it's the food and also some skills. So I'm curious, Dr. Zhu, from your perspective, who are some of those key players that are helpful in bridging that gap?
Well, thank you for having me on, Dr. Ali, and thank you. It's nice to be here with our panelists, and apologize for my tardiness. But yeah, so before I answer that, I want to just kind of briefly just say that I play a little bit unique role. I worked as a contracting consultant physician. I don't stay in one place. So for those of you in the medical world, my most of my career has been locum tenens, which means you're playing a substitute teacher, filling in the spots for wherever there is a need. So my work over the career has spanned me across the country. I've worked with Indian Health on a reservation in North Vegas. I've worked with the VA in Louisiana, and I've worked in community settings in Seattle with refugees, and I'm currently based in Southern California. Over the pandemic, a lot of my work has shifted virtually as well. I own my own business, which really focuses on culinary nutrition and wellness coaching and consulting. And really, my work is really grounded in teaching people the skills in terms of culinary. Back in the day when we used to have a home economics, that was great. And now where our current chronic disease burden lies, I would see it as a survival skill. So the bulk of my work right now, I am an outpatient clinician seeing patients one-on-one. The bulk of my work is really teaching these skills back and really reinforcing the foundations of where your food comes from, how it ends up in your plate, and really how it affects you, your family, and the community around you. So I had to, over the years, amass a lot of different types of resources. And because I travel a lot, I have to meet people where they're at. It's very different than being based in one community and figuring out the resources in proximity. So I actually had to leverage a lot of resources and partners to be able to bring the resources to the patient. And because of the pandemic, I feel like a lot of the technologies have evolved, like meal delivery services, and instead of the CSAs where you contract and get a box of vegetables, for example, I went to a regenerative farm in North Ohio, and being able to talk to the founder of a 2 to 3 generational farm, purely vegetables, purely, never been animal agriculture, and they practice regenerative farming, which represents probably less than 1% of our current agricultural practices right now. And what's interesting about them, using them as an example, is that they have shifted during the pandemic, where they used to be giving out vegetables and selling them off of their local area, but they have shifted to actually distributing vegetable I would say prescription grade vegetable produce boxes nationwide, in addition to Hawaii. So that is a good example of being able to bridge the gap of food access. And although they have a certain price point, they do being able to reach you virtually anywhere would be an example. And for me, a lot of the partners, to answer your question, the key partnership has really been, how do I reach people far and wide, no matter where I'm based out of, in order to teach these skills? So a lot of it is self-created in terms of workshops and demos, both in person and also virtually, but also partnering with health leaders that have created larger summit-based and conferences virtually, especially over the pandemic, where they're able to draw in sometimes audiences in the hundreds, similar to your current webinar. You have around 270 participants, and being able to be on the virtual stage with others to be able to teach back skills and very actionable strategies that they can implement, both for the layperson as well as for healthcare professionals, so they can redistribute the same knowledge and practices to their own respective communities. So
Wonderful. Thank you so much, Dr. Zhu, and thank you for being here. Definitely a unique practice setting, site setting in which your career has really unfolded, and you got at a lot of really important points. And one of them I really want to hone in on is that culinary skills building. And when we think about food as medicine and really where the rubber meets the road in terms of like integrating the produce into your household, do I know how to prepare it? That's one challenge to healthy eating of many. So I'm curious to hear from both of you, from all three of you, before we shift into thinking about, the essential ingredients of successful multi-sectoral food as medicine models. What are some of those like high level, the things that come to the top in terms of practical challenges that folks experience to eating healthfully? And again, this is, we're considering we have the provision of the food, all right? We're providing the food. What are the other barriers to actually eating healthfully? And I'd love us to consider it, from all of our different vantage points, but, thinking about families and caregivers, thinking about the elderly, all of the different facets of our communities. What are some of those challenges and how do you, in your various interventions, address those? So let's start with you, Mr. Dawson, if you wouldn't mind.
Well, no, definitely. I think that, where we are right now, I think that like all of time, we have multi-tiered, multifaceted issues and barriers in place. But I think, what I love to do exercise with a lot of people when I talk to them is I love for us to acknowledge what the pandemic presented, right? And what the pandemic did was it kind of morphed how we approach the work and living and surviving from the macro to the micro. And that's important because what it then showed us was what are our real problems? You know what I mean? And not just, whenever we talk about, problems, a lot of times we're talking in the macro, we're talking high level, and we're not zooming in enough, or we're not reverse engineering so that instead of, trying to divide down, we can multiply out. And so when thinking through a lot of the barriers, I love for people to actually start at the ground level. You know what I mean? Because of course, your family's issues are not the end all be all, and they cannot be multiplied out. But what we want to do is have an exercise of understanding, and owning your perspective, and then understanding and owning the other perspectives when we talk about those barriers. And so, of course, from the family level, we love to, start off with access. You know what I mean? Like, how can they consistently get access to those options while also acknowledging how we position them and championing their choice? Because a lot of times when we're thinking through the disconnect from the medical perspective, it's not speaking to a family and acknowledging that they have a choice in whatever they consume and whatever their health is. And so, there's that lack of empowerment and understanding. Then when you're talking about education, making sure that not only we are acknowledging that there's a different way of educating this generation, but also understanding and making sure that there's not clear-cut biases and different negative tones when we're speaking to that education. Because one of the things that I love to point out is whenever we're talking about communities of color, we love to start from a place of they don't know how to prepare it. When historically, communities of Black and Brown descent have never had issues with preparations of meals. And in fact, and actually, if you go back in time, historically, Black diets were actually more leaning toward healthy produce and not too many proteins. But so when we think about that, making sure that how we're approaching it, we're not using the same siloed approach or saying, hey, how do they know how to make it? You know what I mean? And then zooming out, understanding, okay, when we think about food as medicine, when we think about food intervention, when we think about this, how do we level set and agree on, what we know to be true? Because when we talk about access and we talk about, someone's way of providing for their family or feeding them, there may be 7 steps involved for one family while there's only 4 steps involved for another. You know what I mean? And so when you think about that, when you have, gluten-free diets, when you have, a carb-heavy diet, when you have all, lack of access to, as many greens as you would want, you change how you prepare. And so when we think through, a lot of these barriers, of course there's, just from the clinical perspective, I only know what my partners teach me and what I'm learning on the daily, but even from a food distribution perspective, there's so many different ways that a barrier can be created. And so, I'm just thinking through, okay, how do we make it simple and palatable so that not only the language that the food provider and the medical provider, but also the family, that we're speaking the same language, so that, okay, those barriers may be there, but over the course of time between now and the next 5 years, we've acknowledged that, okay, these are the 10 barriers we're going to focus on, so that within a year, we've eliminated 3 of them. You know what I mean? Because that's the thing. We're not thinking through this in okay, how do we think through the long-term strategy of barriers and how to break them down, as opposed to just saying, well, you know what? These families don't know how to prepare this, and these families don't have access. Yes, but all of us have inherent biases that are kind of baked in to how we've learned and how we've educated ourselves. And I think that every day is a constant educating and kind of rewiring, because we're also doing this on a moving ship. You know what I mean? The society is changing. Where people are is different. How they're learning is different. How they're eating. You know what I mean? And so I think what we all agree on is that the barriers will be there, but if we build strong and healthy relationships, we can kind of track and change as they go along. And I think that's the bigger thing. The barriers will kind of always be there, because sometimes, we're in a generation where healthy eating is a little bit more popular than, the early 2000s. You know what I mean? But with more information and more innovation and technology does not always breed healthier outcomes because of other things. And so I think, when we talk through barriers, trying to make sure that we kind of anchor it at the eye level, so that we can be speaking the same language as those who are battling the barriers, as opposed to looking at ourselves on the other side of that barrier trying to reach them.
Really important points about being extremely, person centric, really first and foremost, starting with the individual. And I think that, considering creative problem solving around the various moving targets of barriers, given our time, I do want to start to move us along and thinking about, okay, the various barriers that families experience or individuals experience to eating healthier, whether that's time, whether that's, excess, whether that is culinary, because that does play a role for some. Dr. Fischer, I'm curious to know your perspective of what some of those essential ingredients are when we think about putting together a multi-sectoral, community, clinical, even public health food as medicine model. What does that look like as we're taking into account those various barriers that individuals might, be up against as it relates to healthy eating?
Yeah, and I want to go back a little bit and just touch a little bit more on that education barrier, because certainly, what we're talking about is greater access. So we are sort of overcoming one barrier, that is access. If you're delivering directly to somebody's home, that's great. There are other barriers that still exist. For example, personal preference or knowledge or skill. And so I think it's critically important in terms of the success of a multi-sectoral program to also offer education. You can't just give the produce. Oftentimes it might go to waste if somebody gets the produce and don't know how to use it or unfamiliar with it. It's not likely going to be eaten. And so I think in terms of successful programs, they really require the marriage of both the increased access and all access to, the food itself, but also access to nutrition education and high quality information, and the ability to think through. That's not to say that the ability doesn't already exist, but this idea that you are your own best source of information. You do not need to follow a list of recipes. You can do with this produce however you want. And so this brings me back to the education piece. This idea that I think it's so critically important, because one of those barriers that we're seeing in terms of why people don't eat fruits and vegetables, even if you put it in front of them, one of those barriers really is this idea of personal preference. I don't know how to do it. My kids won't like it. And it requires some additional cost, not just the cost of purchasing it, the cost of the time and the energy it takes to really make something that your family might potentially not want to eat. And that is a huge waste. It can feel like a huge waste. And so what we're trying to do is offer an educational opportunity where we're giving people the opportunity to make produce into something that's palatable, something that's fun, and something that their kids will try. And then the goal really is to expand the palate and to create more adventurous eaters. The idea is to just simply try these things. It's not as if now you need to be a squash eater or now you need to be an eggplant purchaser. But really the goal is to just expand on some of what folks are interested in trying. And I think one of the barriers that I mentioned earlier is this idea of stress, that at the grocery store, a person who's not familiar with an eggplant would never purchase an eggplant because of the potential waste. And so what we're trying to do is overcome this barrier of the potential, the stress from the potential loss and potential waste. So by giving access to free food, people can experiment and say, okay, I tried squash, I know I don't like it, but I tried beets and I know how to make them and I love them. And so now you have a beet eater for life. And that parent or that kid is a more adventurous eater. And I think that is really a huge step in the right direction to getting kids to eat more produce, more fruits and vegetables.
That's such a good point. And I love the element of really, thinking about these interventions in that multi-generational manner, because we know that chronic disease doesn't just, appear out of the blue later in life. There's those roots that definitely take hold earlier on in childhood and adolescence. So that's a really nice point, as were many of those you made. Dr. Zhu, I'd love to transition to you and thinking about kind of the lifestyle medicine practitioner perspective. And I'm curious to know what advice you would give to our LM colleagues who are looking at starting to expand their reach into the community and build their resource toolkit, if you will. How do you recommend other LM practitioners get started when they want to get into this area of food as medicine and community collaboration?
Mm-hmm. So I'm sure our fellow LM lifestyle medicine practitioners don't need me to say that we didn't receive this type of education in our schools and training, right? And we are making a shift, a wave towards that. And ACLM and other organizations have helped with this, and we're happy to see that. I would say the first step is making sure that you practice this yourself. I think a lot of surveys that we've seen over time is that when you don't have the knowledge, we don't have the confidence to dispense. But if you don't practice it yourself, you're less apt to to dispense it as well. And so before even noticing that lifestyle medicine there's a moniker to it. I practiced it, for a majority of my life. And then I approached the profession and I was like, wow, where has this been, for my career? And how come this was never taught in school? So practicing, the pillars and optimizing the health of all the pillars is paramount for yourself, because the greatest skill set, I've only been an outpatient clinician. I only teach, I practice primary care. And so I'm face to face with my patients. I'm in my clinic right now. And, what I have been able to do is kind of hone basically within a 15-minute schedule of a visit, no matter if, because you're going to have a predominance of chronic disease of their family history. You talk about in 15 minutes, where do they come from? Who in their family members is fighting this disease, right? Have their lab results in front of them and tell them this, is this where you want to go? And within those 15 minutes, I'm able to teach them heart disease, diabetes, high blood pressure, right? Just based off of 2 questions, right? How much animal protein are we eating, right? What percentage does that make up in your diet? And how much of that is home prepared? So I have an idea, right, of how much chronic disease burden types of ingredients and risk factors is going into their body and how much they're actually working for it. Like I said before, culinary skills are a survival skill now, right? And I compare and contrast them that, hey, you got to prep them. You got to be able to prepare your food because you know what's going into your food. And if you're outsourcing, this is the trade-off, right? Economics 101. There's no such thing as a free lunch. There's a trade-off to everything. So even though by convenience you're paying less, right, in terms of fast food, in terms of delivery, right, the trade-off is that it's more expensive, with an ER visit down the road. And I explained this to them in under 15 minutes. And what I've learned over time is that you have to use every golden opportunity to reinforce that over time. Lifestyle medicine is repetition and reinforcement and education of positive, healthy behaviors, right? How they got to this point, whether it's high blood pressure, cancer, diabetes, obesity, wasn't overnight. So I have to tell them, hey, healthy living is going to be a marathon. This is not a sprint. You're not going to Ozempic this and make it go away, right? We are not changing that, overall foundation. So at every visit, I have them come back 6 weeks, 3 months, not a year. You're not coming in just once a year. If they can, and depending on their copay and insurance type and all that, I have them come in more frequently, and I reinforce that education, whether it's leveraging ACLM's material, whether it's my own material, whether it's other credible organization. Another thing too is, we have to fight the forces of social media. Most of my patients, where are they getting their health information, or should I say misinformation and disinformation, is really Google and social media, TikTok, right? And so a lot of the work that I'm trying to do at ACLM, for example, is, pardon the phrase, beefing up our social media game, right? Being more comfortable in terms of public speaking. The more that we can present ourselves online, the more they're going to see us as leaders, and being able to say like, oh, my doctor is practicing this and they're doing X, Y, and Z, and they're giving me this kind of health information, the better. The more like we said, we can't do it alone. We have to do it together. So the more that we can create this wave of healthier, credible information on social media, where majority of people are relying their information, because a lot of people don't go to their doctor's offices. They only go when something is wrong. So I have to do a paradigm shift. I have to say, listen, your body is a car, right? We sell, lease, rent, buy back, sell back these cars. We have several cars in our lifetime. But guess what? The body you're living in is one car. And if you only had one car to maintain for the rest of your life, what would you do? Most people take care of their cars way better than their physical bodies, right? So it's a paradigm shift. It's a paradigm shift. This takes reinforcement over and over and over again. So for my LM practitioner, every golden opportunity that you have to educate them is a change of their trajectory of where their future is going to go, and it's not a repeat of their chronic family medical history.
Thank you so much. That's that power of the one-on-one, and having those one-to-one interactions be the launch pad to subsequently connecting your patients and families to other key resources that will be helpful based upon their expressed goals and desires. So really important points that you made, Dr. Zhu. So time flies when you're having fun. I mean, we could keep going for hours and hours. And I want to make sure that we actually do have some time to take a few questions. So I want to start to shift us into thinking about, and this will be a little bit of a rapid round. Okay. So rapid round responses of having you all each share. Really, I'd love you to share one element, one brief story that I think embodies what success means to your work. Okay. So when you think about particularly health equity and food as medicine, is there a person or a resident or an individual that comes to mind that really shows what success is as far as your particular work? And this will be a rapid round, and then I'd love you all to have a moment to do your takeaway high levels. Dion, would you mind starting us off with your reflection?
Absolutely. Even though I'll be honest, I'm not conventional when it comes to this question. Only because as a Black leader, I'm I'm asked this question more often than I would like. Because when we talk about the success of the work or the things that stand out, a lot of times we're always asked about an anecdote or this fantastical story of someone lowering their sugar levels and losing 100 pounds or something like that. But what I probably would focus on is just what we've been able to do internally with how we've been able to build. When it comes to our food is medicine work, I think about that our partnership with Food Smart, we've grown our food is medicine patients we're serving throughout Cook County to more than 1,500 patients per week, and we're gonna probably triple or quadruple that by Q1 of next year. I think about our partnership with Rush, which is instead of it being last mile delivery, is point of care outside of the emergency room. And I just, the thing that stands out is making sure that we're flexible and nimble enough to meet this need. And I think that, when I love to think about our team, how we've exposed them to being practitioners and not just recipients, and how they're helping people become healthier and find ways to have produce prescription interruptions and programming in lives throughout the county. And that's what I think about. You know what I mean? Of course, we have examples, but I try my best to not, share those stories that aren't my own without permission, because also those are their stories to tell. For us, we're in logistics, we're in delivery, and our programming and our workforce development and what we've been able to create. It's allowed us to be participants in how we look at food as medicine and how we're educating, how we're connecting, how we're serving, and that's what I think about.
Thank you so much, Dion. Dr. Fischer, would you like to share briefly?
Yeah, I'd love to. So your question is to share a story that exemplifies the work, or was there something more specific?
No, that's perfect. Just something,
Okay.
the spirit of your work.
Okay. Well, I have shared a lot about this idea of stress being a major barrier to eating fruits and vegetables. And in our program, what we're really trying to do is increase access to the food, but also nutrition, the education and the information. And I want to go back to something Dr. Zhu said, that this idea that information is out there. But in terms of what we've heard from our patients is that when they hear it from their doctor, they put a lot of weight into it. Unfortunately, at the same time, when they hear it from TikTok or whatnot, they put a lot of weight in that too. But I think being LM practitioners, you have a very, very strong position in the lives of your patients to be able to say, this is an important thing, and this will contribute to your long-term health if you if you pursue healthy eating habits. And so in terms of our patients, when they see that my doctor is recommending this, they're likely to participate. When they participate, they're very likely to recognize that they like and are more willing to eat fruits and vegetables. And we hope that in the long run, we're collecting data on this, we hope in the long run that this increase in fruit and vegetable consumption will translate into long-term health outcomes, less risk of diabetes and heart disease and weight-related, diet-related chronic diseases. And I would encourage any of the lifestyle medicine practitioners out there who are interested in pursuing this to start small and start finding local partners.
I love it. Thank you so much, Laura. All the practical tips are so helpful, especially when you're kind of new to this work and looking at how you can get going to implement it yourself in your local community. Dr. Zhu, do you have anything you'd like to add?
Yes, if I understood the question correctly, given examples of what we've kind of bestowed and how it exemplifies. So I'm covering for a physician that's on leave of absence. I do locum tenens, and so brand new practice. I'm taking over the practice, and I just kind of explained how I approach a visit. And so within 15 minutes, I go through that spiel, right? That script, and everybody's a case by case basis. 3 patients kind of come to mind that I consider them rock stars. By following exactly what I just said, I've had one patient that lost 30 pounds in 2 months, second patient 21 pounds in 3 months, and then the third patient 10 pounds in 3 months. And what was similar through their stories and case testimonials were that they, were able to receive the information, process it, and be able to implement it themselves. I gave them the resources, right? If the education was the easy part in terms of giving them the education, I told them if they don't know how to cook, here are some options, right? For example, I gave them examples of meal delivery services, which have exploded during the pandemic, right? And this is a gap of a bridging of a gap, because if they don't know how to cook with plants, they at least know how it shows up to their doorstep. And I say to them, listen, you don't need to, pay for this forever, but I need you to, know what this looks like in front of you, right? Then it generates ideas and inspiration for them to do it themselves, right? And make sure that they have an accountability partner, whether it's their spouse, whether it's a girlfriend, whether it's a family member, in terms of working out, right? We go through all the pillars of health, right? And I just do this. And I literally, with each one of these patients, I had only literally 2 visits within that time span with them. So effectively, they did most of the work, right? And so I was actually surprised when they came to me, and when you look at the scale, they dramatically dropped. And a lot of them, the common through line is they implemented them immediately. When you have patients that are more hesitant, when you have patients that are more reluctant or they're currently in denial, you have to do a little bit more hand-holding, right? So you also have to tell them, like, here's the facts, here's the statistics, right? If that doesn't work, because everyone receives information differently, is what I've learned, right? Kind of like cooking. Some are audio learners, some are visual learners, and some are kinesthetic learners, right? You have to meet them where they're at, because it has to click with them. In order for that change to be sparked. And so some of those you have to, do a little bit more hand holding, and it takes a little bit more time. So those are just 3 examples that I considered that, would be examples of what I've implemented so far in a short period of time.
All right. Thank you to each one of you all for sharing your perspectives in terms of your work and impact and how it really shows up for individuals, which is really what the point of this all is. So I want us to give you all a moment to share your high-level takeaway point, and then we're going to open it up to Q&A. And one note, folks, we did kind of have a slower start, so we're going to run a tiny bit over 1 o'clock, if that's okay. This is going to be recorded, and so if you have to log off, totally understand, but you will have access to the recording. So I'm going to give our panelists a chance to just wrap up, share their takeaways, and then we'll have a moment for a couple of questions. So in closing, I know that there is so much more we could have covered. This is such a rich topic, and I suspect some of the questions will help us get into a couple of the dimensions we did not cover, get the chance to in questions. But I would love each of you to have a chance to just share your high-level takeaways, and then we'll open it up to the floor. Dion, you are up.
I'm gonna try to go quick because there were a lot of good questions. So I want to make sure that we're able to kind of get through that, since that's the payoff for people sitting through to listening to us talk. But no, first one is just reduce food insecurity by providing recipients with condition appropriate access to nutrition support and affordable food options. Improving health outcomes through personalized nutrition education that promotes sustainable health outcomes and overall well-being, including weight loss and clinically necessary diet and lifestyle modification. Utilize social media to advance nutrition education and bridge the gap between healthcare providers and food access. And I'll just end there by just saying that I don't think the social media utilization will go down on the public and patient side. I think it just needs to go up on our side. And I think that we have to continue to adapt because I think the overall goal is for people to be educated, and we have access to them, and they have access to us. And so just continuing to figure it out, finding that beautiful formula so that we can save and have as many healthy lives out there as possible. So I'll stop there.
Thank you so much, Dion. And next up, we have Dr. Fischer to share just a couple quick takeaways for you all, and then we'll move to the Q&A.
Quick takeaways. As we've discussed here today, keeping the community in the center of everything you do is really key to making these efforts successful. We could talk a whole seminar on what that looks like, but I'll leave it at that. We are finding that providing greater access to healthy and affordable food and the education to use that food really does improve healthy lifestyle behaviors in children and their parents. And we're hoping eventually that this is going to translate to helping reduce that burden of chronic disease later in life, and of course that cost of healthcare across the next decades. Finally, I really want to end with sourcing locally is a really huge opportunity to bring this full circle and impact the community that you're working with in terms of economic opportunities, but then also to prioritize working with companies that utilize sustainable practices and regenerative practices so that this work does not do further harm to the health of the planet while trying to improve the health of the humans that live on it.
So thank you so much for those great takeaways. And Dr. Zhu.
Thank you for everyone here. Thank you for Dr. Ali for bringing us together, and for all the participants. So I would say my takeaways are, if you are a primary care physician, if you are practicing in person, sometimes a lot of us are practicing telemedicine now, I would say be very confident and brush up on your public speaking skills, and go around your community, hold events, go to your local church, go to a food pantry, go to a food bank, go to a community of sorts, go to a meetup, go to farmers markets. I actually had a booth a couple of weeks at a farmers market. Why would a doctor go to a farmers market? It actually makes a lot of sense. And by the way, a lot of farmers markets don't take doctors. They apparently just want craftsmen and farmers. So it was really hard to get into a farmers market. So my point is that, brush up on your public speaking skills, because one of the most effective strategies you do is not only one, practicing lifestyle medicine yourself, but also being able to speak in front of a large audience. For me and my work is just one-on-one. The amount of time and energy that I put in a one-on-one visit, I could easily do that in a larger audience of 10 or 100, right? And being able to create that ripple effect that spreads out to the community. Turn on some light bulbs so they can find you later on, or tune in to a social media that you put up out there. Like Dion was saying, and like I was saying before, it's a rising tidal wave of social media. It's not going to go away anytime soon. So being comfortable in front of the camera is also very important. If you're not comfortable in front of a camera, then partner up with someone that has a podcast or that's going to have a virtual summit soon. Having that community of healthcare professionals that speak to the masses is also very important. So I think being able to put yourself out there and not just practicing medicine conventionally is very, very important to really fight the myths and disinformation that we have.
Awesome. Thank you so much to each one of you all for sharing your insights and experience. And I am now scanning the chat, and we'll try to take maybe 2 questions or so until I'm told that we need to wrap up. Absolutely. So our first question here is, I'm wondering if maybe farmers or grocers who usually throw out fruit might be differently shaped, or maybe might have a small dent. Instead of throwing that fruit or other produce out, perhaps they can sell it or donate it to food banks or shelters or some place like that. Dion, I'm going to throw this one to you. Is this something that is a practice? What are your thoughts on this question?
A couple of thoughts really quick. First thought is one way of fighting lack of access and food insecurity is preventing food waste, but is not the only way. And I think that when we look at the messaging over the last, decade or so, it has went heavily towards not wasting food, but that is not the crux of it. If you look at 2020, we did not have a food problem. We actually had a food distribution problem. And so when we think through, solving issues, the first thing is that when we think through farmers, their main issue is not that they're throwing away, the things that may look different or may have grown to different sizes. Is actually their access to market. And so a lot of times when you think through farmers and their ability to get to market, they're battling mandatory minimums, a lot of different things to get access to market. And as a result, they don't have the access to a lot of the high quality contracts or procurement opportunities that a lot of the bigger farms are getting. And so when we think through that, I try to always use a proactive approach to connecting the food system and then ultimately food as medicine work as opposed to reactive. Of course, there are different things that individual parties can do with that for that produce that may look and feel different. But you also have to look at how they're positioned and if they're bringing in enough revenue to sustain what they're actually doing. And I think that what we don't want to do is overly generalize it to the point where we're telling all of them, because even historically, Black farmers have historically not been paid what they're worth when it comes to what they're growing, and we don't want to get in the habit of viewing their product, which is just as good, from the lens of, hey, don't throw that away. No, what they're growing is good and they should be paid what they're worth. And so I think we want to make sure that, that tide rises all boats and everyone is compensated. And then from there, we can then look at, once they're compensated, being able to then be creative and impactful with all of the other things that are left over. But I think we would have to address the main thing first, which is making sure they have access to market. They have supply chain set up. They have a lot of different relationships set up so that they can bring in diversified revenue streams so that they can not only continue to provide top shelf options when it comes to what they're growing, but also make sure that they can take care of their family and do the same thing.
Awesome answer. So multi-tiered. I have another great question here that I'm going to have Dr. Fischer answer. How can you help people overcome the barrier and belief that eating healthy is expensive, apart from produce boxes or vouchers that are generally limited? This is something you hear a lot.
Yeah, this is a really great question. And I just want to say I've been answering questions through chat as well. So
Awesome.
I didn't realize these were going to be the Q&A questions. But anyway, so if you want follow-up to any of the answers I provided in Q&A, I'm happy to do that as well. But regarding how do you help people recognize that eating healthy is not expensive? Well, I think I'm of two minds here. On the one hand, it very much is expensive, especially for families who have limited resources and have limited expendable resources. It is expensive. At first thought, this idea that, oh, I'm going to buy a pound of carrots, I'm going to bring them home. I don't know what to do with them. I don't know if my kids are going to eat them. I don't know if my family is going to eat this food. I'd rather spend those $6 on, bread and cheese to make grilled cheese that I know my kids are going to eat. So there is this barrier to eating healthy that the legitimate barrier that people have that is an increased cost, and it's the cost of time, effort, stress, potential waste. And so the idea of how do you overcome this without giving access to free food, that's very, very difficult. I mean, on the one hand, offering education through like SNAP education, they do a really great job of identifying the groceries you need to buy and food plans that you can follow that will fit within a limited budget. So SNAP Ed is a really great resource outside of offering a food prescription or produce prescription. On the other hand, offer in your clinic some free tastings. You don't have to do a 6-month delivery. What if in your clinic you had maybe you have a partner dietitian or a health educator who just buys a couple zucchini and show in office how to how to work with a zucchini, so that you're overcoming those very real and legitimate cost barriers, and that cost that's not just the monetary cost.
Incredible. Thank you so much for that really thoughtful response, Dr. Fischer. I think we will take one last question, and I'd like to share it with Dr. Zhu. The question is, I'm beginning to reach out to healthcare professionals to see if they'd like to team up with me. I did the culinary health coach certificate. What is your advice for me to help convince them to bring in someone like me to support patients by educating them on how biometrics can be improved through healthy food habits? It's a great question.
Yeah, that's a great question. So I think their response to this really depends on how much they value your skill set, right? Some people could look at a culinary skill set or culinary coaching and not really pay much mind to it, don't think is as valuable. So it really depends on the office, the practice manager, and the physician that makes decisions for the facility or an organization or system to know how much it's it's valuable for them. So that could lead into bills and costs and reimbursement rates and things like that. So I would probably say to have a conversation. I would say have a conversation in terms of what are the pain points? What do patients struggle with? Is it an educational gap? Is it, do they have a dietitian on staff? Do they have a therapist, behavioral therapist, to be able to kind of work through the barriers in terms of in terms of that, in terms of behavior change, right? Because that could be one option as well. And what kind of resources that they have in their disposal, and what's the actual proximity, right? And so depending on that answer will determine how valuable. Obviously, we think it's valuable all the time, right? Wherever we can get it, wherever we can put it in. But I think it starts with the first conversation and understanding where their gaps are. Listen, chronic disease is everywhere. So if you could focus on the chronic disease and being able to emphasize, hey, this is where my skill set is. This is how I could, assist. It's being creative in terms of what that looks like. That could be a lecture series. That could be a lunch in service, right? That could mean a public speaking event, right? A large health system sometimes holds events. You could turn that into a community event and be able to showcase yourself. Like I said, going back to public speaking, sometimes you just need to put yourself out there, give a talk, and then people can make a assessment based off of that to say, oh, you know what, she or he would actually be useful in X, Y, and Z, right? So you kind of have to display and demonstrate what you're trying to advocate for before they can actually give a solid answer. But I think it starts with a conversation first.
Wonderful. Thank you. Thank you. Thank you so much, Dr. Zhu. Thank you to Dion. Thank you to Dr. Fischer. I really appreciate each one of you all sharing your time with us this afternoon. Thank you all so much to our audience. I know you all were very patient and we had so much to get through. And I know there are many questions that are yet to be answered. And so I will share them. I'll have the ACLM team try to share them out with our panelists so that we can try to get you some answers, because they were really good, some of them quite technical questions that I know you all will appreciate having the answers to. And one last thank you to our HEAL working group and also to ACLM for hosting us today. And I wanted to share just a couple of quick reminders. If you're not already an ACLM member, please, we would love to have you. And also consider joining the HEAL Initiative. We have our annual conference coming up next month in Orlando, Florida. And we also offer through the HEAL Initiative these HEAL scholarships, and they are geared towards underrepresented minorities, clinicians specifically, who are looking for some assistance around getting trained in LM to then subsequently bring that back to higher medically vulnerable communities. So that is something to look into, and a new application cycle opens up in January. This is the first part of a 3-part webinar series. And so these are the next couple of dates coming up. So please be on the lookout for more info there. And last but not least, thank you all so much. And we will be sending you all a follow-up email, try to get the lingering questions answered. And again, thank you all for your patience and your great engagement. Thank you again to our panelists.